Good evening, everybody. Thank you very much for having me here. At the outset, I must express my sincere thanks. Good evening, everybody. Thank you very much for having me here. At the outset, I must express my sincere thanks to my teacher, late Professor Director Dr. K.C. Mohanty, the organizers of today's program, my close friend Dr. Bansi Sabu and his entire team, Dr. Mangesh Tivaskar, again my very close friend and my diabetologist. All my respiratory cases, all my complicated cases, all diabetes management is done by Dr. Tivaskar, and whatever little bit of experience I have in managing respiratory infection and diabetes, the credit goes to him. All my patients, all of you who chose to be here on this working day evening, your presence encourages us to do more and more program and educational partners for today's program. The agenda for next 15 or 20 minutes I have is to give you some data, association of diabetes and normal lung, association of diabetes, lung infections and immunity, and some take-home message. While preparing for this talk, I was looking at my data and I just roughly scanned last 100 patients that I saw in my OPD. And I had this mix of cases with tuberculosis, upper respiratory, lower respiratory tract infections, stable asthma, COPD, interstitial lung disease, mainly IPF, and sleep apneas. And when I look at what was the comorbidity diabetes in them, and I found significant, all my 7 patients of OSAS had 100% diabetes. 2% of my asthmatics were diabetic, 8% of my tuberculosis were diabetic, 16% of my drug-resistant tuberculosis were diabetics. And you can see that elderly patients, diabetes was one of the major comorbidity in my respiratory cases. When I look at my admitted patients today, this is today's data, and the associated diabetes as comorbidity. Out of 7 AECBs, 3 are diabetic. Out of 3 sepsis, 3 are diabetic. 1 tuberculosis, 1 diabetic. 1 hemoptysis, same patient is diabetic. 1 community acquired pneumonia admitted today is luckily non-diabetic. And out of 5 ILDs admitted today, 2 are diabetics. And when I look at the association, it makes me think that immunity plays a major role. Every infection does not develop into disease, and we have understood this better during this COVID times. There may be a patient who may get completely asymptomatic COVID positive, and there may be some patient who develops a florid disease and you may even lose them, and there comes the role of immunity. And then what are the factors which reduce your immunity? And when I kind of think about it, these are the things that come to my mind is prolonged use of cytotoxic and immunosuppressant drugs, including steroids, high stress level, certain acquired immunocompromised status, certain food, chemicals, fertilizers, insecticide, but yes, diabetes and associated comorbidities like your liver failure, your kidney failure, patients on dialysis are responsible for lowering your immunity. And you all know this better than me, that why are we concerned about diabetes? Huge morbidity, huge mortality. So many people would die because of this diabetes and diabetes related complications by the time we finish our talk. Pulmonary infections in diabetes is characterized by altered host defense in the entire body and more locally in lung, especially by altering the respiratory epithelial and ciliary function. Characterized by serious clinical features, longer duration, more frequent complications, and needless to say, more mortality. In diabetic patients with end-stage renal disease, there could be pulmonary infection-related mortality tenfold than general population, and hyperglycemia can alter host defense and makes him at a higher risk of acquiring infection. It impairs wide range of functions in neutrophils and in macrophages. They are particularly important in limiting invasion by pyogenic and other bacteria. So your neutrophil and macrophage are responsible for limiting infection, but hyperglycemia impairs their function, and movement of phagocytic cells to the site of infection is impaired. Respiratory infection is a leading cause of mortality and morbidity, and of course the cost worldwide, not only in your area and my area. On the population level, patients with diabetes are more susceptible to respiratory tract infection due to a number of mechanisms. There may be age, unhealthy lifestyle, decreased immune function, increased risk of aspiration due to gastroparesis you may have because of diabetes, pulmonary microangiopathies you may get, and frequent comorbidities you may have with diabetes like renal failure and stroke. Not only infections, there are acute infections like community-acquired pneumonias, viral, sepsis, fungal infection, but also Lungs are vulnerable with vascular complications like pulmonary vascular event, cardiac vascular event, airway disease, and there may be autonomic neuropathies leading to lung function changes. Approved uncontrolled diabetic will have PFT impairment, the FEV1, FVC, and FEV1 by FVC, all may be impaired. Interestingly, also patients with impaired glucose, intolerance of glucose, IGT, they may also have changes in lung functions, including lung compliance. Going into each, respiratory infections, mainly the acute infections, staph is a major bug responsible for both community-acquired and nosocomial pneumonia, and there is a high nasal carrier state. Diabetics are thought to be at an increased risk of this staphylococcal pneumonia. 30% of diabetics are nasal carrier for staph aureus compared to 11% in healthy individual, more than double. And the rate of nasal carriage of staph is directly related to glycosylated hemoglobin. So, better control and less likely of carrier state. Worse control, higher chances of them having a carrier state, and more so developing complications of staph pneumonia. There is a higher incidence of gram-negative bug also with uncontrolled diabetics, especially their susceptibility to laryngeal trauma. Patients admitted, you're doing intubations, etc., putting them on high risk of getting gram-negative infections. They stick to upper respiratory epithelium and also increase that kind of colonization in diabetic patient. Subsequent risk of aspiration due to gastric paresis, gastroparesis in diabetic patient is also known. Be it anaerobic infection, be it atypical infection, including Legionella and Mycoplasma, diabetics are at higher risk. The most common complications in diabetics because of acute respiratory tract infection, lower mainly, is effusion, the parapneumonic effusion, empyema, and sepsis or bacteremia. Fungal infections are also not uncommon, and during COVID times also we saw a lot of COVID-related complications, especially in diabetics who had uncontrolled diabetics and who went into complications like ketosis. And this is one patient of diabetic ketoacidosis where we diagnosed mucor. You can see that there was a big consolidation on left side, and on biopsy it was confirmed mucor. Viral infection, in fact, there are theories which used to talk about viral infection as a cause for type 1 diabetes. Viral infection may be dangerous in people with diabetes. There is increased risk of complications from disease like influenza. There are HBV, HCV again are more common in diabetes than all those who do not have diabetes. Influenza also is a cause of morbidity and mortality in diabetic patients, and during episodes of influenza pneumonia, the rate of ketoacidosis rises, and the mortality chances because of this ketoacidosis also increases. You can see that X-ray showing bilateral fluffy shadow. This was a confirmed case of influenza, and just 48 hours after, you could see that there was huge consolidation bilaterally, mainly peripherally. This was also a confirmed case of influenza. Not only that, there are challenges in using antibiotics. Say, for example, aminoglycoside you're using. It is not that you can't use aminoglycoside, but you have to be extra cautious because they share the common end organ damage, and which is nephrotoxicity. There may be issues in using fluoroquinolones. Of course, no chest physician, no physician, learned like you would use quinolones routinely in practice. But then if you have to use quinolones for whatever reasons, you know that there may be issues of hypoglycemia. Tuberculosis does not spare anybody, and these are a few famous people who had co-infection, that means who were diabetic and had tuberculosis. It is worth noting that TB is a shadow of diabetes, though it is long recognized, but it is highly underappreciated, and I feel sorry. A lot of chest physicians also forget to check sugar levels, forget to ask for simple sugar testing when they are managing diabetes. And this, I showed this slide earlier, but look at this. The lungs are more vulnerable in diabetes, but yes, tuberculosis for sure. There is higher incidence of tuberculosis in diabetics, and managing tuberculosis in diabetes is hard. You need to manage both disease simultaneously. This is a remarkable historical fact which says that autopsy of diabetics in 1883, there was presence of granuloma in 50% of those autopsy cases. And before insulin, it was said the diagnosis of diabetes was death sentence, and leading cause of death was tuberculosis. During 20th century, it was said that a diabetic who does not die of coma dies of tuberculosis, especially if patient is poor, especially if diabetes control is poor. 14% of my TB patients have diabetes. 5 to 30% of diabetics get TB with rifampicin resistance, and hence drug resistance also is a problem. With diabetes, spread of MDR, XDR, XSDR remains threat, and it becomes very expensive to manage diabetes and tuberculosis together. There are various mechanisms by which diabetics are at higher risk of getting tuberculosis, or tuberculosis predisposes to diabetes, including IgT in diabetes. There is higher conversion to over diabetes. TB causes acute severe stress, fever, inactivity, malnutrition, stimulates various stress hormones. Plasma levels of IL-1 and TNF-alpha are increased, stimulating stress hormones, and there are various disengagements in lipid metabolisms as well. There are a lot of physiological changes that also happen in pulmonary physiology due to diabetes, that is diminished bronchial reactivity, reduced diffusion capacity, mucus plugging and mucomodulation is altered, and reduced ventilator response to hypoxia. With all that, let's look at how do we prevent these respiratory infections in diabetes, and we need to manage strict control of sugars. Vaccinate against flu and pneumonia. We must vaccinate every diabetic. We must vaccinate, for that matter, everybody, but diabetics for sure with influenza and pneumococcal vaccine. Raise patient awareness about it. Practice good hand hygiene and cough etiquette. Social distancing holds true not only in COVID, but tuberculosis, especially if tuberculosis with diabetes, and smoking cessation goes a long way. I would urge all your diabetologists to ask for at least twice a year X-ray chest and regular medical examination for sure you will do. And any diabetic who has sudden cough, weight loss, or any probably a new shadow coming up on X-ray must be investigated for tuberculosis. And building immunity in diabetic patients is of paramount importance. Though immunity is very complex subject, immunity would require presence of it would need genetic factors, it would need environmental factors, and it would need individual lifestyle changes, including regular exercises, good diet, and nutrition. But out of all this, I believe environment we may not be easily able to change it. Genetics is probably beyond us, at least at this date, and hence what is modifiable is a lifestyle changes. Smoking cessation, a good diet with good fruits, vegetables, regular exercises, maintaining good weight, good sleep, minimum stress, and all recommended vaccine is one quick formula or a short formula to build immunity. And there is evidence to show that various micronutrient deficiency occur in diabetics, which would alter your immunity, and that is vitamin A, B6, C, vitamin E, selenium, iron, copper, folic acid is a few of the known micronutrients which can alter immune response, and there are enough studies for this. The micronutrients would enhance insulin action through activation of insulin receptor sites, which serves as a component for enzyme systems. Chronic hyperglycemia causes significant alteration in micronutrient status. And one important component of improving immunity is to prevent and treat this deficiency. And many times, only diet may not be enough, and you need to supplement this, their diet with this combination of all these micronutrients. People with diabetes have 30% lower vitamin C concentrations. Uncontrolled diabetics and zinc may lead to decrease in, there is reduced reabsorption of zinc from kidney, and yes, there is more loss of zinc. 14 to 48% of patients may have hypomagnesemia. Vitamin B12, B1 deficiencies are known in normal individual also, and more so in diabetics, more so if they have acute infections. And hence, if you can probably have a formula which is a lot of micronutrients, especially focusing on vitamin C, zinc, magnesium, B1, B12, and folate, this would help prevent the micronutrient deficiency and would help build immunity. I would summarize by saying that diabetic patients are immunocompromised owing to dysfunction of immune system due to elevated sugar. They are more prone to infections, mainly the respiratory one. The common bugs responsible are strep, influenza, mainly the H1N1, tuberculosis, and not to miss COVID-19. They have a lot of micronutrient deficiencies, mainly vitamin C, zinc, magnesium, thiamine, B12, and folate, and a diet rich in this micronutrient must be supplemented along with smoking cessation, regular exercises, good sleep, and management of stress to improve their immunity. Thank you very much. And this way, we could help our diabetic patients. Thank you very much for your patient hearing.